And our first presenter is going to be Tim Bruckner from University of California, Irvine.
Thank you. Good afternoon. I'd like to acknowledge NIMH for the research funding. The content expressed in this presentation is, however, my own and not necessarily the views of NIMH. In the U.S., over 1 in 5 children aged 13 to 18 suffer from a severe mental disorder, yet less than half of these children actually receive care for their disorder. The undertreatment occurs more commonly among African American youth than non-Hispanic whites, and African American youth tend to use the emergency department more often for psychiatric care than do whites. This poses several problems. It poses healthcare costs, but also public health costs. Because emergency departments, I'll refer to them as EDs, typically provide suboptimal care relative to care treated in non-urgent settings. And this portends poorly managed symptoms throughout to adulthood, which might exacerbate psychiatric disparities later on. And this excess use increases healthcare costs. It might disrupt patient flow within the context of an already overburdened yet underfunded emergency department system, and does not arise from difference in mental health prevalence of the condition. Within this context, federally qualified community health centers, or CHCs, might help. These are providing primary and routine outpatient services that could plausibly affect the demand for ED visits. Community health centers are federally funded and provide care regardless of the patient's ability to pay. It provides care predominantly for those under Medicaid and without insurance. And these centers have expanded dramatically in the last decade by about 70% in terms of patients seen. And they target medically underserved areas. So they focus on low-income, disadvantaged communities, which have often prominently ethnic minority populations. Recently, the estimate is that they serve around almost 25 million Americans. So could the expansion of CHCs be a disparity reduction strategy for psychiatric emergency visits in the ED? Well, African Americans are notably overrepresented in services to seeking care at the CHCs. And so it's plausible that if we expand this primary care and outpatient services, they might reduce the disparities in around 1.1 million youth psychiatric visits. That said, there's cautionary tales from other experiments. So in Oregon, when there was a public health expansion, healthcare expansion of Medicaid, expanding primary care also expanded the demand for emergency department services, which was not necessarily the intent of their expansion. So it challenges the assumption that primary care could necessarily substitute for ED care. So the hypothesis is pretty straightforward. Does the system-wide increase in service use through the expansion of CHCs reduce African Americans' reliance on the emergency department for psychiatric care among youth? To test this hypothesis, I retrieved emergency department data from the SID and the SED. These are statewide emergency department databases. The SED, SEDD, is the treat and release outpatient ED. But if your ED visit transferred into an inpatient facility, you're recorded in the statewide inpatient database. So cases in SED are much more common, about 6 times more common among youth than the SID. So most emergency department visits are treat and release rather than an overnight stay. In the US, the SID and the SED capture about 110 million ED encounters per year, and selected states partner with the Healthcare Utilization Project to collect this emergency department data, and coverage among hospitals is virtually complete. The SID and SED data are visit level, so they have diagnosis, age at admission, gender, race, ethnicity, insurance, among other individual level factors. And we restrict the population to those aged 5 to 24 years, and 24 years coheres with the WHO and Healthy People definition of youth. We include a variety of ICD-9 diagnoses to identify psychiatric ED visits, including mood, conduct, anxiety, and other disorders that you see there. And there are 9 states over the 2006 to 2011 period that we evaluate. We identified these states because, first of all, they participate with the SID and the SED. They collect race data. They have a non-trivial fraction of African Americans in their state. And the community health centers grew substantially in those states. It's a little surprising perhaps to you, and it was to me when I applied for this grant, is that many states dropped the race ethnicity variable after 2011. So that poses a problem. California in particular, which had a large fraction of CHCs, so that's why the analysis period went to 2011. To get the exposure variable, so the CHC information, we get that from a publicly available data request from the Uniform Data System, and this is a federally funded system that retrieves the patient and encounter level summaries of each CHC. The CHCs have to report this information to the federal government as a condition of getting funded. For that reason, we think it's of high quality. And so almost 100% of the CHCs complete the reports. And there are a few variables that we think could gauge the intensity of primary care in these populations. First is the total number of African Americans seen at CHCs, and we divide that by the population in the county. Then we have number of patients in the CHCs diagnosed with a mental disorder per population, per 100,000. And then also we get the number of mental health visits per mental health patients, which we think of as an indicator of potentially continuity of care or the intensity of care that a mental health patient has seen at the CHC. The approach is one in which the exposure of interest is county level, so the county level community health center intensity, if you will. And the outcome is whether the visit was, the psychiatric emergency department visit, was to an African American or to a white youth. And so we're really essentially modeling the likelihood that the psychiatric ED visit is African American relative to white as a function of expanding community health centers. Keeping the outcome variable at the visit level allows us to control for age, gender, and type of health insurance that the individual has, which could be strong confounders of who is likely to go into the psychiatric ED. Then we enter one by one the variables of interest so as to avoid multicollinearity, African American seen, number of patients with a mental disorder seen, and visits per mental health patient. And there's a variety of control variables we use both at the individual and at the county level. There's also county and year fixed effects because, as you could imagine, there are trends in psychiatric ED visits, and there are also aspects unique to a county that don't change that much over time, but might dramatically influence the likelihood of help seeking in that county for psychiatric care. Provide you a couple descriptive statistics. First of all, this plot shows that mental health visits expanded at CHCs over time. In fact, it's about over doubled in a 6-year period in terms of mental health visits. So community health centers are serving a lot of patients, and especially more mental health visits over time, rapid expansion. African American patients are also rapidly being seen at CHCs. And this, again, predates Obama era. A lot of CHC expansion actually occurred under the Bush administration as well. For the ED part, the use psychiatric visits, it's less clear that I'm separating this out by state, but if I were to aggregate this across the state, well, we also have a secular increase in psychiatric ED visits among youth. It's around a 40 to 50% increase there too. Okay, so clearly there are a lot of things that are trending, and from a statistical perspective and an inference perspective, we need to control for these secular trends before examining the relation of that county's mental health care system increase on psychiatric visits. A few descriptive statistics on the SED, so this is again the outpatient ED visits, the treat and release, 2.8 million visits Again, only looking at African American relative to white, so a quarter are African American, the other 3/4 are white, more female than male seen in the psychiatric ED, and 30% with Medicaid as their source of payment. Moving to the inpatient, the SID, ED visits, much fewer visits overall, around 30% are African American, and more representation of Medicaid as source of payment than in the treat and release. So here's the take-home results. This table summarizes 6 separate regressions. So I don't include covariates in this just because it would get too busy. But essentially, I look at the SED, the outpatient treat and release, psychiatric ED, and the SID separately. And then I look at the 3 key independent variables separately. So you have 1, 2, 3, 4, 5, 6 different regression results. And I highlight the 2 in yellow that reject the null. Both of those are in the SED, the treat and release outpatient psychiatric ED facility. So first of all, counter to expectations, increase in overall mental health visits in the CHC correspond with an increase in psychiatric ED visits. Okay. However, the intensity of services offered, or the number of mental health visits per patient, corresponds with a reduction in the likelihood of an African American psychiatric ED visit relative to whites. Okay. So, in terms of that, interpreting this second coefficient here, so in some sense the protective CHC coefficient, a 1 standard deviation increase in mental health visits per patient, which is about 0.3 additional visits per year, corresponds with around 3 fewer outpatient psychiatric ED visits for African American youth in that year, in that county year. So it's around a 0.7% reduction, pretty modest. If you aggregate this to the 150 counties over the 9 states that have expanded CHCs, it's around 4,200 African American psychiatric ED cases averted if you were to attribute causality. Okay. And we think of this moderate effect as reasonable, given that the overall penetration rate of CHCs, despite the fact that they've expanded to around 25 million people, is on average around 8%. So it's relatively low in these counties. There's a variety of caveats. First is that this is a system-wide research question, so we don't know how individuals wind their way through the system. We're not tracking individual treatment at CHCs and subsequent likelihood of ED visits. We also have no information on the quality of mental health care that these CHCs deliver. We have some screening, fraction of children or fraction of persons over 12 that have a depression screening, and that comes online in 2014, so you can evaluate that starting in 2014. I have no information yet on the troubling recidivism of psychiatric ED visits, so that's a next step to see the likelihood of those who already sought psychiatric ED care. Do they come back, or is there some potential avenue for continuity of care in the primary care setting? And there's also obviously this issue of the extent to which CHCs integrate behavioral care into their practice. There's other cause-specific hypotheses we'll examine down the road too. So overall, the volume of mental health visits at CHCs might actually indicate acuity of care or some other help seeking that corresponds also with increased psychiatric ED visits among African Americans. But there might be promise in looking at visits per patient, because that might indicate a community or the CHC's willingness to have continuity of care. And that corresponds with a reduction in African Americans' reliance on the psychiatric ED for care. So in that sense, enhanced continuity of care might deserve more attention and could overall reduce African American youth over-reliance on the psychiatric ED. I'd like to acknowledge my co-authors, Lonnie Snowden at Berkeley, Jung Ho Yoon at Oregon State, and Bharath Chakravarti and Parvati Singh at UCI, and thank you for your time.
Okay, our next presenter is Lori Halloran from Veterans Administration in San Francisco.
How do I do it on this one? All right. So I'm going to be presenting on a project my colleagues and I conducted on utilizing culturally competent technology to improve suicide prevention efforts among a high-risk population. So what high-risk population are we talking about? In this case, it's those that are experiencing homelessness in the U.S. So over the past 2.5 decades, an increase in homelessness has been witnessed. And about 500,000 individuals are homeless within any given night in the U.S. And that means that between 13 and 14 million individuals will experience homelessness at some point during their lifetime. This group is also increasingly diverse, and we'll get to that when we talk about the participants in the study. So why were we concerned? Suicide amongst the homeless is a critical issue, and what we find is that suicidal ideation is about 10 times that's demonstrated within the general population, and suicide attempts have been found to be 2 to 6 times that's demonstrated within the general population. However, recent findings note that the estimates are actually significantly higher than this, approximately 9 times those that we see in the general population, so about 112.5 per 100,000 individuals, identifying homeless individuals as a population of incredibly high risk. We know that there are some identified risk factors, some general factors up here, and we know that methods tend to be more violent. However, there's still a lot of information that's lacking. Examination of suicide attempts and completions amongst homeless individuals present a host of challenges, such as difficulty tracking and identification of these individuals, leading to a scarcity of reliable information. So thinking about suicide amongst the homeless, there are specific groups that are demonstrating particular risk, and those are individuals that affiliate with a minority identity. So ethnic minorities are overrepresented in the homeless population relative to the general population. And these individuals experience a great deal more adversity and discrimination than Caucasian individuals experiencing homelessness. However, these experiences differ amongst minority groups. For example, African Americans experiencing homelessness are more likely to struggle with social relations and report poorer ability to manage skills necessary for daily living than Latino, Native American individuals experiencing homelessness. Additionally, we know that generally those with minority affiliations demonstrate increased risk for suicide. And individuals with numerous minority identities, so those affiliating as an ethnic and sexual minority, have higher suicide rates than those of a single minority status. So thinking about what we aim to do, first is just to examine risk for suicide amongst individuals experiencing homelessness. And second was to identify specific risk factors related to suicide within this diverse population, because risk factors have tended to be broad up until this point. And we also wanted to investigate how culturally competent technology could aid identification of and effective resource connectedness for those at risk for suicide. Specifically, we wanted to examine the feasibility of adapting a culturally competent risk assessment into an iOS application with automated outputs to increase accessibility and aid resource connectedness among this diverse group. So our study site was Central Arizona Shelter Services, the largest provider of emergency shelter in the state of Arizona, who provides 700 individuals with supportive services every day. And I just need to talk a bit about the importance of their partnerships. So they were actually very invested and approached us. They recognized, based on critical incident reports, that suicide was an issue at their site, but they wanted support in identifying how they could recognize this and how they could support their clients. So, to talk a little bit about the burden of providing services, when thinking about those 700 individuals that access services every day, their supportive service needs are managed by 8 case managers. And so those individuals have to identify and refer their clients appropriately. However, their main job is not to provide mental health support. They're providing all sorts of social supports in that setting. And the assets really were that case managers are often aware of the resources in the community. However, some of the challenges were in actually that clinical assessment and identifying who was at risk and who was not at risk. Additionally, there were crisis supports available. However, those were much more reactive rather than preventive services, which is what the site was interested in implementing. So thinking of the participants, what we'll find is in the self-reported race and sexual orientation of our participants, you'll see that there are higher minority affiliations, both in race and sexual orientation. We had 124 participants, all adults, ranging in age from 18 to 75. Mean age was about 45 years of age. All right, so this was a mixed methods study. They did a qualitative interview on a whole host of issues related to violence and suicidality. These were also the measures that they filled out. Here we're going to really focus on these two, the cultural assessment of risk for suicide, which is a 39-item measure that's a culturally competent measure of risk for suicide. And then the Suicidal Behaviors Questionnaire Revised, which is a brief screener for suicidality. Within these types of settings, measures such as the SBQ are often used. All right. Additionally, when talking about that iOS feedback, what we see is this is what patients or clients would see on the left, and then what case managers would get on the right, at least part of what they would receive. So upon completion, the assessment was scored and individualized feedback was given, demonstrating the scores across scales, subscales for the participants. And then if there was an elevation in any of the scales, they would receive some qualitative feedback on that. And then on the right, a breakdown of all of the scales and subscales, color-coded for mild, moderate, or severe elevation. And then beyond that, they would get information about critical items that were endorsed, talking about how support could be used for those critical items. And then each scale where elevation was present, they would get extended feedback to try to target referrals. So looking at those two measures again, across majority and minority affiliations, what we found is that within the SBQ, minority affiliating participants were 1.3 times less likely to be identified as at risk. And then when considering these individuals through their scores on the CARs, they were 2.6 times more likely to be identified as at risk. And when we look at how that aligns with the qualitative interviews, we find that the CARs was capturing a much more accurate depiction of risk present within that setting. Specifically within the CARs, what we found is that the minority stress subscale was capturing the risk that was present. So minority stress examines the experience of individuals based on levels of acculturation, maltreatment, and social inequalities. And that was really seen to be a driver of some of the risk for suicide within this setting. Additionally, we received feedback on the outputs given, and what we found is that qualitatively the strengths were that information in graphs were understandable. There was an alignment between the elevations identified and the patient's or participants' lived experiences, and the information provided was relevant for the setting that we were providing this information in. And so these the suggestions that were given actually aligned with referrals that were available to them. Also, recommendations that were given were that the patient graphs should actually be more similar to that the provider received, and that there were some color coding to help identify the risk elevations. So then summarizing some of that information, again, you have the clients, the case managers that are tasked with managing the needs of those clients. About 44% of clients identified with a minority status, and approximately 25% of minority affiliating clients were identified as at risk for suicide. So what does this all mean? The CARs demonstrated increased sensitivity for capturing overall risk of suicide amongst individuals identifying as a minority, and significant differences were found, specifically assessed through that minority stress scale. Additionally, the iOS output was seen to be understandable, appropriate for the setting, and provided meaningful guidance. Ultimately, implementation of the CARs through this technology has the potential to improve effective risk assessment and aid response efforts within this resource-limited setting. Of course, there were some limitations. Generalizability, this was an emergency homeless shelter. So while the individuals were homeless, they were receiving services. There wasn't any method for recruitment. We attempted to capture the varying levels that individuals were sort of working through or progressing through at that site, and all items were self-report. When thinking about future directions, our aim is to develop preventive solutions to the high rates of suicide in this population. And so really that's through implementing a suicide prevention intervention at this site. Some of the items that are going to be completed to do that are constructing a culturally competent suicide center based on those critical CARS items that the iOS output already identifies and provides feedback on. To utilize this automated screening, to give feedback on resource referrals, so additional guidance. Now that we have some input from case managers of the referrals that they feel most confident in and have strong relationships with in the community, making sure that those are identified. And so when they are strapped for time, that some of those decisions can already be made through the app. And then to examine the challenges and benefits of implementing this app, and actually considering its utility in additional service organizations, some that are partnered with this setting. Additionally, to improve staff training to just increase the awareness of suicide risk factors within their environment, and discuss how to manage the risk that is presenting. And then I think that is it. All right. I have a minute.
Okay, our next presenter is Tomoko Udo from State University of New York, University at Albany. Well, welcome. So
thank you and good afternoon. I'd like to start with presenting the data from our the recently published study on the prevalence of DSM-5 eating disorder in U.S. adults. So as you can see, so the prevalence of all eating disorders is higher in women than men. And for anorexia, prevalence is higher in non-Hispanic white compared to non-Hispanic black and Hispanic. But the difference is not that substantial for bulimia and binge eating disorder. But the big important picture here is that the eating disorders are not specific for Caucasian women, but it can happen in both men and women and all race groups. So traditionally, research on eating disorder utilized clinical sample, but over time, researchers started to realize that proportions of men and ethnic racial minorities in their study, which a lot of time none in their sample, did not really reflect population-based prevalence of eating disorder, suggesting that men and ethnic racial minority may underutilize specialty treatment. And if you look at the developmental trajectory of eating disorder pathologies, or associated psychiatric or physical condition comorbidity by sex or race ethnicity, then research found only very few significant differences. But again, these are based on clinical sample or community sample through a convenient sampling approach. And to our knowledge, there is only one large epidemiology study on ethnic racial minority or the ethnic racial differences in eating disorder, and they confirm that they are significantly less likely to utilize mental health services. But they didn't examine sex differences, and the question was not specific to mental health service utilization due to eating disorder symptoms. So the service utilization could be due to depression, substance use disorder, anxiety disorder, which are pretty high comorbidity disorders in eating disorder. So we need more population-based epidemiological studies. Why? Because they're helpful in identifying where the disparities are in terms of access to care, but how we may be, and also how we may be able to reallocate the resources, personnel and financial resources, to address these disparities. So to address this knowledge gap, we aim to obtain prevalence of estimates of seeking help in U.S. adults with lifetime eating disorder diagnosis, and also briefly describe sex and ethnic racial differences in clinical profiles of eating disorders. So we used the data from the National Epidemiologic Survey on Alcohol and Related Conditions Third Wave. This was collected by NIAAA between 2012 and 2013. And the data contained over 36,000 non-institutionalized U.S. adults 18 years or older. And to diagnose psychiatric disorders, including eating disorder, they use structures interview administered by trained layperson interviewers. For this study, we included respondents who met criteria for lifetime DSM-5 anorexia, bulimia, and binge eating disorder diagnosis, and answer questions regarding the help-seeking behaviors. And these are the sample size for each disorder. And survey also included question about whether respondents ever sought help from these 6 forms of help, specifically for primary symptoms of each eating disorder. So for anorexia, it was for low weight. And for binge eating, it was for eating large amount of food. And for bulimia, it was for eating large amount of food or engaging in extreme compensation behavior. So I'd like to start with presenting prevalence of help seeking in total sample. So we found that only 1/3 of respondents met the criteria for lifetime anorexia reported ever seeking help for their low weight. And it was about 2/3 for bulimia, and it was less than half for binge eating disorder. So they're pretty low. And across 3 eating disorders, sorry, I had an error, but not working. So the most common, commonly used help source is the mental health specialist. But for bulimia and binge eating disorder, it seems that respondents also reported to use self-help support group and also 12-step group as a help source. And in terms of sex differences in help seeking for anorexia, we didn't find any significant differences in ever seeking help between men and women. However, if you look at the individual form of help, it seems that men are more hospitalized and use medication compared to women. And for bulimia, we didn't find any significant sex differences in help-seeking behavior. And for binge eating disorder, we found that men are significantly less likely than women to ever seeking help, even after adjusting for sociodemographic characteristics. And we also found significant differences in mental health specialist utilization, help support group use, and medication use. So ethnic racial differences, we found that Hispanics were significantly less likely than non-Hispanic white to report ever seeking help for low weight. And we also found lower rates of mental health specialist utilization and also 12-step group utilization. We found when you just look at the prevalence that racial minorities are significantly less likely to ever seeking help for bulimia compared to non-Hispanic white. And non-Hispanic blacks across different forms of help, they are less likely, they utilize any form of help less than non-Hispanic white, except for this emergency room utilization, which was higher in non-Hispanic black. We also found significantly less likelihood of utilizing any help in race ethnic minorities for binge eating disorder, and we found that lower utilization of mental health specialists among racial ethnic minorities, and for Hispanic, lower utilization of self-help support group relative to non-Hispanic white. So this is the results of differences in clinical profiles by sex and by race, and we have several significant differences, but here I'd like to highlight 2 things. So one is the binge eating disorder by sex. So men reported significantly earlier onset of binge eating disorder and significant longer years with episode and later onset of first seeking any help than women. And for racial differences, particularly Hispanics seem to report that later onset of first seeking any help relative to non-Hispanic white. So overall big picture conclusion from this presentation is that men are less likely than women to seek treatment for binge eating disorder, and this can be problematic given that they also reported significantly earlier BED onset, longer use with episodes, and later age of first seeking help. So this means that they might suffer from binge eating disorder longer than women. And when you just look at the prevalence, ethnic racial minorities are less likely to seek treatment for all eating disorder, and particularly for Hispanic, they generally report later age of first seeking help. We also found some sex and ethnic racial differences in how they utilize different sources of help. For example, we found less utilization of mental health specialists and ethnic racial minorities. And going back to total sample statistics, only 1/3 of individual with anorexia and about half of individual binge eating disorder reported ever seeking help. This is definitely a suggestion that we have a lot of room to improve access to care for eating disorder, regardless of sex or ethnicity or race. Given those findings, it is crucial to further our understanding of what the barriers are to access to care among these underserved populations. For example, social determinants that might generally influence medical help-seeking behavior, such as insurance, availability of specialists in a community may be something worth looking at. We were not able to do this because the data didn't have this question. And unfortunately, the bias is still there, that eating disorder is Caucasian women's issue. So this sometimes lead to fear in men and racial ethnic minorities about being stigmatized when they admit that they have an eating disorder. So that might deter them from seeking treatment, or even under-recognize or denial of eating disorder symptoms. Same thing for medical community. It is still, many doctors think that that's a Caucasian women issue, so they might not pick up the symptoms or not even ask the question when they interact with these populations, so they might miss the opportunity for important referral timing. We also need to really identify better way to educate about eating disorders and encourage help seeking in these populations. For example, we know that men and ethnic racial minority tend to use primary care for any kind of medical problems, and also community health organizations. So there might be a good setting to educate and also conduct screening to increase detection rate and also educational opportunity about eating disorder in these populations. So there are several limitations in this study, and I want to focus on two here. This is because I adjusted for sampling design, so it is a population-based estimate. However, as you somewhat may probably notice that sample size for certain cells are small, so some estimates may not be statistically stable. And because of the limited sample size, we didn't include Asian Americans in the study for the racial and ethnicity analysis, but they are also affected by eating disorder, so future study regarding their eating characteristics is important. And this is not just for this study, but this is for anyone who's interested in using this data set to study about eating disorder. The diagnostic interview used for this survey is actually not tested for reliability and validity of diagnosis of eating disorder. This does not mean that it's not valid. It's just that we're not sure how sensitive this instrument is in terms of picking up the eating disorder. So this is some kind of one caveat that you should be aware of. So this is disclosure, and that's it. Thank you.
Okay, our next presenter is Brianna Last from University of Pennsylvania, and you have your technology.
Let's see. If
Okay.
I can get it on here.
Are you going to do the notes on?
I'm going to try and do it.
I
here.
asked the guy, I didn't know anything about it.
Okay. Let's see if that works. Oh, okay.
All right.
I'll just do it from my laptop. That's okay. That's okay. Yeah, thank you. Hi, everyone. Thank you for inviting me to this exciting panel. Lots of great presentations, and I apologize in advance. I'm going to be looking at my notes on my computer because of some tech difficulties. So I'm going to be talking about sociodemographic characteristics associated with symptom severity, specifically post-traumatic stress disorder symptom severity in a community mental health study. I want to talk about the huge gap between what we know from research and what's actually done clinically in practice. So despite the fact that there's tons of evidence that certain psychological interventions, including trauma-focused cognitive behavioral therapy, are effective for the treatment of post-traumatic stress disorder in youth, uptake of these interventions are really limited. And though precise statistics on sort of how many youth are actually receiving evidence-based practices are kind of difficult to find, most evidence indicates that they're not really receiving evidence-based practices when they go into the community. And a lot of researchers refer to this as the kind of the valley of death. So, you know, there's this kind of continuum, translational continuum from basic biomedical research to clinical science and knowledge, and then clinical practice. And that sort of, that valley over there is the valley of death, where we have these sort of evidence-based treatments, and then what we see in practice is not really kind of reflecting what we know from the science. And when we kind of probe therapists who are implementing therapy in communities, they have a lot of ideas about evidence-based practices. And in particular, you know, a lot of their attitudes to them are, you know, that they don't really fit their clients. So something that we hear pretty consistently from in community mental health agencies is a therapist like this, our favorite therapist, for those of you who watch The Sopranos, they'll say, my clients are different from participants in randomized controlled trials. They're just not a good fit for trauma-focused CBT. And so they have this perception that the actual research that's being developed in randomized controlled trials is not applicable to their clients. And so that partially may explain why there is this sort of research evidence to practice gap. And in particular, these opinions tend to be endorsed, at least from our experience, at Penn, they tend to be endorsed by clinicians working with youth living in poverty, and often living in situations where a lot of their basic needs aren't being met. And so there's a real question as to whether or not there is some validity to these perceptions. You know, a lot of them will say, like, our clients just don't have the bandwidth, or they're not able to undergo this treatment. And there's a lot of evidence to suggest that these clinicians may not be wrong. So there are a lot of studies that look at the sociodemographic characteristics of individuals who go on to develop PTSD. And I know this table is kind of to read from far away, but socioeconomic status, discrimination resulting from racial, ethnic minority identification, and neighborhood crime, whether you measure that on an individual level or a neighborhood level, are all associated with both increased exposure to traumatic events, increasing the risk of developing PTSD, increasing the risk of relapse once you undergo treatment, and less likely to recover. And so what I really want to highlight in this slide is that low SES, lack of education, and minority status was very, this huge meta-analysis was associated with PTSD. So kind of the sum total of a lot of this research is suggesting that maybe clinicians aren't actually wrong about their perceptions. And so what this study hopes to do is to kind of bridge that death valley, to kind of get a sense of let's kind of characterize the sample in these community mental health clinics and see if what these clinicians are saying is actually true. And so this is bridging that valley, and hopefully that's me. So the present study. So we want to characterize the sociodemographic characteristics of youth presenting for treatment in an effectiveness trial for trauma-focused CBT in the city of Philadelphia. And then I want to examine whether these sociodemographic characteristics are associated with PTSD symptom severity when youth present for treatment. And just to give you a background on the study, I don't want to go into the details too much, but this was a study that was rolled out in the city of Philadelphia. It involved training clinicians in trauma-focused CBT in community mental health agencies, and it was a partnership between the University of Pennsylvania and the Department of Behavioral Health, and it started at around 2012 and has been ongoing. So we're actually in phase 2 of the trial after those 5 years, and that was just to give you a sense of the timeline. And here's just some kind of sample demographics of who these clients are. So again, this table is kind of hard to see, but it's roughly split male-female. We get a good, broad range of ages. So it's roughly split between kind of young kids, middle teenagers, and then older teenagers. And then I'll talk a little bit more about the racial demographics a little bit in a second. And the total N is about 114 youth. So what are the socio-demographic characteristics that I tried to examine in this data set? So I wanted to look at race and ethnicity. I also looked at housing instability, neighborhood socioeconomic status, and neighborhood crime. And so I'll first talk about race ethnicity. So just to give you a sense, our sample was predominantly African American or ethnic minorities. So it was 48%, so about half, and 37% were Hispanic. And of course, there were other like ethnic identities and races. And a lot of clients I actually did evaluations for this study often said that they didn't fit into a lot of the categories that were presented. And then housing instability. So I just want to mention first off that because it's really difficult to consent, a lot of youth that are involved with DHS, which is the Department of Human Services, we actually we weren't even able to talk to youth for the research portion who were in foster care. So this is likely an underestimation of housing instability that is experienced by youth seeking mental health care in the city of Philadelphia. But we were lucky enough to at least have a measure to get at, for those who have not been DHS involved, for those who have not experienced any type of social services, at least at the point of entry where we were talking to them, have they experienced housing instability? And so we had this measure that's by SAMHSA. It's a national outcomes measure, and it asks two questions. Basically, in the past month, have you been homeless? Have you had to stay at a friend's? And then in the past 30 days, where have you spent most of your time living? So have you been living with a primary caregiver, or have you been living with a distant relative in a group home or in like another type of setting? And so this just breaks down the housing instability when youth were presenting for treatment. And so the majority of youth had not experienced housing instability, and that's what we would expect because we weren't seeing kids who were in foster care. But about 14% of youth did experience some level of housing instability in the past 30 days, which is substantial. And then what we did with the second question about sort of where you've been living most of the time in the past 30 days is I created a variable that basically said like if you live with your primary caregiver, we'll call that normative housing, and then everything else is like non-normative, and then we kind of dummy coded that. And so most individuals were living with a primary caregiver, and about 12% of you were not living with their primary caregiver when presenting for treatment. And this is just to give you another sense of what the normative housing breakdown looked like. So there were some kids who were living in a residential treatment facility. And next, I also looked at neighborhood socioeconomic status. So what's really wonderful is that the American Community Survey is sponsored by the Census Bureau. They ask a bunch of sociodemographic questions, and what I did was linked all of that publicly available data to the addresses of our clients and matched it to their census tract to get a sense of sort of what their neighborhoods look like, and identify some of the socioeconomic characteristics that are really important in influencing PTSD symptom severity. And so this is just a breakdown of the median household income of neighborhoods where our participants lived. And as you can see, it is slightly positively skewed, but predominantly they're living at a pretty low income. Like that's where the sort of modal number of participants are. And so on average, the median household income of where PACS participants lives is $30,000. And just to give you a sense, the national average is about $35,000. And then this is a breakdown of the percentage of individuals living below the poverty line. So PACS participants were living in neighborhoods where there was pretty significant poverty. The percentage of individuals living below the poverty level in their neighborhoods was 34%, and the national average is about 14%. And in Philadelphia, the statistic is around 28%, so it's still even greater than Philadelphia, which is a poor city. And then this is a statistic on kind of the percentage of individuals over the age of 25 who only have a high school education or equivalent. And PACS participants tended to live in neighborhoods where about 38% of individuals only had a high school education. So also pretty low. Great. And then finally, this is another proxy of socioeconomic like kind of capital in a neighborhood, and it's basically the occupied housing units in a neighborhood. So if you have a lot of occupied housing units, it's a kind of proxy for the wealth and stability of the neighborhood. And we found that participants tended to live in neighborhoods where about 85% of houses were occupied. And the national, and in Philadelphia, that's pretty equivalent. So this is not particularly different. So just to give you like a bird's eye view, these are kind of like all the statistics in a table. So the left-hand column looks at PACS participants in the neighborhoods that they live in. Then the second column is the Philadelphia average. And as you can see, for the most part, even compared to like an average Philadelphian, our PACS, the kids who are seeking treatment for PTSD tend to live in much poorer neighborhoods. They tend to live in neighborhoods where educational attainment is lower, the housing variable wasn't particularly different. And especially when compared to national statistics, which is the third column, our PACS participants are experiencing a ton of socioeconomic adversity. And you can quantify this difference empirically. So I did some both proportion z-tests and also two-sample proportion t-tests, and there were significant differences in median household income between our PACS participants and the Philadelphian average, as well as in terms of the percentage of people living below the poverty line, but there were no significant differences for educational attainment and housing. When you look at the national average, there were significant differences on all the measures except for the housing measure. Okay. And then finally, neighborhood crime. So another leveraging of publicly available data, the Philadelphia Police Department releases all of its crime incident statistics. So what I was able to do was match participants' police districts to the publicly available data that's out there to see if neighborhood crime was influencing their symptoms, and also just to characterize the neighborhood crime that they kind of live with. One thing that we hear from therapists a lot is like, our kids are going back to neighborhoods that are really unsafe. How can we expect them to recover when they're just kind of being chronically re-traumatized by neighborhood violence? And so we just wanted to kind of characterize what that looks like in their neighborhoods. And so this is a bird's eye view of the total crime incidents in the 6 months before baseline, when youth are presenting for treatment. I should mention that we couldn't use the full sample because even though a lot of the clients were seeking treatment in Philadelphia, not all of them had Philadelphia addresses. So this is about 86 of 114 participants. And one thing I should mention is that when I was looking at this data compared to Philadelphia statistics for crime and measuring them, there were no significant differences. So it's likely that just Philadelphia is a pretty crime-ridden city, and these kids are living in neighborhoods where they're experiencing comparable amount of crime. So what are some of the conclusions that we can draw? So the first is just that our PACS youth experience significant socioeconomic adversity and neighborhood crime compared to national populations, and in terms of the socioeconomic adversity, definitely compared to the average Philadelphian as well. And likely efficacy trial participants. A lot of RCTs do not publish socioeconomic characteristics of their samples, so we don't have a sense. Those that do tend to be predominantly white and tend to be more affluent. And so that's something to consider when we're thinking about the generalizability of those trials. these statistics these sociodemographic factors don't statistically predict symptom severity at baseline, and they don't moderate treatment outcomes. So I don't show this, but I did a lot of analyses looking at their symptom severity at baseline based on a couple of measures, and also looking at their outcomes. And kids don't seem, these characteristics don't really seem to influence those statistics. Nevertheless, these factors may account for the overall high symptom severity in our youth. So almost all of youth had really clinically significant PTSD. And that may create barriers to symptom improvement in therapy that we can't really quantify. And figuring out what that is kind of where future research, I think, will go. And in the future, I think there should be a lot of pragmatic RCTs, which include subjects who have a lot of diversity in their sociodemographic characteristics, and who share a lot of those characteristics with those who are actually seeking mental health care in the community, so we can get a better sense of whether or not this research generalizes. Great, thank you.
Okay, our final speaker is Luther Kalb from Johns Hopkins University.
Great. So I want to thank everybody for attending the very last session of the day, for those of you that hung on. So today I'm going to talk to you about national trends in psychiatric emergency department visits among youth and young adults in the United States. So we know roughly about 1 in 5 adolescents and actually adults experience a psychiatric disorder in their lifetime. Roughly 75% of adult psychiatric disorders actually onsets in childhood. Yet only about half of both youth and adults receive treatment in their lifetime. And for leading causes of death, the population we're going to focus on today is youth and young adults between 5 and 24 years of age, and you can see that mental health is directly related to the top causes of death, particularly homicide and suicide. And you can see in blue at the top is unintentional injury, which is mental health often plays a role in those events as well. Suicide is increasing. We've heard a lot of discussion today about increasing suicide rates. It's going up across populations. I'll draw attention particularly to the blue line at the bottom, where it's increasing among adolescents and young adults. And so all of these factors show up in the emergency department. And so the emergency department is a place where individuals with chronic mental health issues and acute mental health issues seek treatment. And the emergency department is a unique place because it is required to serve all patients at all times under all circumstances. So they are open 24/7, 365. And the emergency department is actually not designed as a mental health facility, not surprisingly, but they still are tasked with treating our population. And so the emergency department is actually, the Institute of Medicine released a report a couple years ago. It's really kind of at the breaking point. And the reason is because visits are going up, but actually emergency departments are going down. And so visits are skyrocketing, and it's creating a real overburdening and overpopulation, and wait times are increasing nationally. And the emergency department actually doesn't have any financial protection. So like I said earlier, they'll serve anybody for any reason. So whether you have an insurance or not, you're going to be treated. And so the emergency department is really caught in a unique confluence of factors in the United States. And so historically, if you look back at the literature, visits for psychiatric purposes are going up among youth. Since they've been tracked, they're going up. And so what I'm going to present to you today, not a shocker, they're going up. And so between roughly 5 and 7% of psychiatric, of all visits are mental health related. And so, but few studies really focus in on young adults. They usually lump it as children and adults. And so today I'm going to talk about trends in emergency department visits across the United States between 2011 and 2015 among youth and young adults, We're going to focus in on age, and we're going to focus in on race and ethnicity for trends and also correlates of these visits. And then I'm going to present separate data on visits due to suicidal ideation, self-injury, and suicide attempts. And so the data for this study comes from the National Hospital Ambulatory Care Survey, the NIMH, which has been around for a long time. Actually, we started in the 1970s. And it is actually, the data is gathered through chart review. So there are trained abstractors who go in and retrieve information for diagnosis and reason for visit across a randomly sampled emergency departments across the United States. It does not include VA hospitals, military hospitals, or federal short-term hospitals. So these are community settings. And all of these data are actually made publicly available. They're de-identified, so this study was exempt from IRB review. And so the outcome for this study is a psychiatric emergency department visit. And I applied the criteria by Simon and Schoendorf, who did published a study in 2014. They're from the NCHS. So they are very familiar with this data set because NCHS is actually part of the people who put this together. And they provide a really nice section of tables, and I'll give you a snapshot of that, of what they identified as mental health visits. But there's a total of 6 sources of information to identify a psychiatric visit. There's diagnosis, provided by the provider, and there's 3 of those, and then there's reason for visit, which is provided by the patient. And so there's a standardized classification system for reason for visit to identify what in the participant's own words, why they're going to the emergency department. And then I classified them using pretty standard schema, look at mood or depression, mania, anxiety-related disorders, behavioral problems such as aggression, conduct disorder, and hyperactivity, substance use and abuse, psychosis, and then suicide attempt, ideation, and self-injury. And then there was an other category. And so this is a catch-all. This could be personality disorder. This could be a mental health procedure. This could be a social issue. And so here's a reason for visits. These are diagnoses that you can see. And then the actual reason for visit schema where they classify things. And so for demographics, I'm going to separate the ages out into 3 groups, 6 to 11, I'm going to call children, adolescents is 12 to 17, young adults 18 to 24. And then the racial classification is actually federally identified. This is provided by the data set as white, black, African American, Hispanic, and other. And one thing to note, one limitation with this data set is race was actually missing on about 20% of the population, and that is actually imputed by the NCHS. So we have all the participants, but for race it was imputed within the data set. And so there's a ton of visit-related information. We have time of visit, length of visit, day of week, whether it was urgent or not, whether a mental health professional was seen, and that's actually just a long list of providers that was seen during the visit that was checked off by the coder, and then discharge disposition. And so the analysis is a survey-weighted logistic regression model. So the outcome is probability of visit. I chose that rather than an account because it takes into account the denominator change because visits are going up, so we're going to look at proportions. And we're going to look at trends overall for suicide visits and within age group and also racial and ethnic trends. And then for correlates, the outcome is a multinomial logistic regression. And so the outcome is age and race, looking at the differences within psychiatric visits. And so here is the proportion of visits increasing over time among youth 6 to 24 years of age. And you can see it kind of meanders and starts increasing between 2011 till 2014, and then there's a big bump. But this really does not provide the overall landscape of what's going on. So among children, the proportion stays quite flat, around 2%. And so among adolescents and young adults, there's an increase. And so the asterisk down at the bottom represents statistical significance at less than 0.05, and all the weights were applied to this analysis. So you can see that there's 9% at 2011, and it increases to 2014 among youth 12 to 17 years of age, and there's a large bump at 2015 among this group. But among young adults, there's this proportionate increase every year that goes all the way up to over 13%, or right around 13%. So that's more than 1 in 10 visits. So among race and ethnicity, among whites at the top, There's a slow meandering increase that is not statistically significant, although if you think about the number of visits this increased nationally, that's actually a significant number. So it goes from right above 9% to slightly under 11%. But among Black and African Americans, there's a flattening and an increase at 2015, but among the Hispanic population, there's an increase that goes from 5% almost to 9%. That's almost a doubling among that population in a 5-year period. So among, for suicide attempts and self-injury, among adolescents, there's a significant increase. There's a large bump at 2012 to 2013, and that remains the same. So this is the proportion of suicidal ideation and attempt within psychiatric visits. So among psychiatric visits, almost a third is related to self-injury and suicide. That is really high. And so among the other populations, it's actually much lower, and it stays relatively flat. So when looking at reason for visit, the comparison group here is young adults. So you can see that mood is highest is a leading reason for visit. And so it's highest among adolescents. Behavioral problems is highest among children, which is significantly greater than young adults. And then you see the inverse, which is substance abuse problems is highest among young adults, not a surprise, significantly lower in adolescents and young adults. And then psychosis is quite low, but then we see the suicidal ideation is highest among adolescents. So among the racial and ethnic groups, mood is highest here, but for Black African Americans, behavior problems was significantly greater than whites. Whites is the comparison here. And so for for substance abuse issues, it's highest among whites, lowest among Black African Americans, and lowest among the other racial categories. Psychosis is low, and there was no significant differences among the suicidal ideation. There was a slight bump amongst the other, but that's a fairly small group. So thinking about what's related, what are differences among and descriptors of children related to visits? So children, and the reference group here is young adults. All of these findings are statistically significant, and these are odds ratios. And all of these models control for year, region, sex, arrival time, weekend, race, and insurance type. So children were more likely to be male. They were less likely to have a weekend visit, more likely to have an evening visit, and far more likely to have a behavior visit compared to young adults. For adolescents, there was a lot going on. And so this is a real takeaway from this study. So they were more likely to be Hispanic, have afternoon and evening visits, urgent visits, which is related to self-injury and suicide. They were more likely to see a mental health provider, more likely to be admitted, have SI, have greater number of diagnoses, and also have a primary diagnosis. And if we think of a primary diagnosis as the primary reason for a visit. So among Blacks and Hispanic youth, so among Blacks and African Americans, they were actually less likely to have an urgent visit. And so by urgency, that's when the provider provides a classification of the visit, but they were more likely to have a behavior-related visit, which has been reported in previous research as well. And for Hispanics, they were had a lower number of psychiatric diagnoses, which may be underreporting and underdetection. So this was really striking. So the proportion of psychiatric emergency department visits that saw a mental health professional was 1 in 6. That's 16%. And so more than 80% of all these individuals saw a physician. But when it came to actually a mental health provider, unfortunately, we don't know what type of mental health provider, it was really low. And another takeaway is the length of these visits. So if you look at the blue quadrant of this pie graph, nearly 1 in 5 was over 6 hours in time. That is extremely long. This is far longer than your typical visits. And so this is creating overburdening and overcrowding in the emergency department. And we've heard stories, and there's been releases in the media about young people sitting in the emergency department for very long periods of time waiting for inpatient hospitalization. And so that's reflected in these data. So ultimately, the visits are rising. The difference between 2011 and 2015 is actually 700,000 visits just between those 2 years. This trend is really driven by adolescents and young adults and non-whites. And so adolescents had the most acute. They're the population greatest risk within this data set, and only 16% overall saw a psychiatric mental health professional, and the visits were very long. 1 in 5 was more than 6 hours. And so thinking about the implications, what's driving this, I think we're all still trying to figure out, right? Is there changes in mental health in the community? Is it differences in reporting by the patients or identification by the providers? Or is there a change in service-seeking behavior? Are more people going there because it's an accessible source? And so what are we going to do about it? So I think we need to serve patients where they are. You know, thinking about getting, if more than 1 in 10 visits is mental health related, should we get mental health expertise in the emergency department through telemedicine and getting more mental health professionals, providing more linkages to the community? And ultimately, how can we get out to the community? How can we get to these people before they go to the ED? How can we prevent these visits if we can get them mental health care directly? And so there's mobile response. There's some research on that, mostly in adults. Respite centers, care centers. Can we provide settings that are designed specifically for mental health? And then are there new models of care? So there's been a real challenge in preventing these visits. There's a recent meta-analysis that looked at outpatient linkages, mental health services in the education setting, and not find any influence of them in preventing these visits. So I think we're really tasked with thinking about how we can serve these families where they're at, but also get to them in the community. That's it. Thank you.
Thank you. All great presentations. And I want to, before turning it over to the audience for questions, I want to take the chance that I have now for me to ask you guys some questions, and I'll turn this to the audience as well. So Mike Freed mentioned earlier that one of my portfolios is the Disparities in Mental Health Services research portfolio. So any subsequent research coming from the studies that were presented here would be coming to my portfolio, and I'm the person there with the challenge of thinking about what should we be doing, what are the new things that should be being done, and just building from a little bit of what Luther said at the end of his talk and some others alluded to is we have a lot of information documenting stuff about disparities, descriptive stuff about disparities. What are the differences in diagnoses, where people go for treatment or seeking help, time spent seeking help, et cetera. And the question we continually have is how do we move from that descriptive data to having evidence-based studies about what to do about it, right? Is there something, so my question to the group and people from the audience as well is, with the data that you now have, what can you pull from it to tell us in an evidence-based way what should we be doing to try to reduce the disparities that you all have documented? So folks are nodding, which gives me hope that someone's going to chime in with some thoughts. I know I'm putting you on the spot here, but Tim?
I could just, I tried to find something, within the...
Can you use the mic?
Oh, sure.
Please.
This ties in a little bit to some of what Luther was presenting. Community health centers have expanded dramatically, and if actually the work that we've done is replicated, it seems that it might not be on its own a great disparity reduction strategy, but if you increase the mental health services that are free of charge by twofold in 10 years, you might reduce the barrier of mental help seeking among minorities, because those community health centers target low-income ethnic minority communities. They might not do it as efficiently as we think for a great evidence-based practice. We might not have good measures of quality of mental health care in those community health centers or the extent of integration, but there was some non-null result about the amount of visits per patient that seems promising. I like to focus on the promising part.
use the mic so the virtual folks can hear you.
Yeah, I think that's a really good question. I think I have two responses. The first is in the mental health world, we can think about adapting treatments that are more suitable to clients whose resources are constrained or who are dealing with unique issues like discrimination. And I think that having more sort of culturally sensitive treatments is one possibility. But I think ultimately, a lot of the sort of history of disparities research is showcasing the way in which the system has failed people who are really vulnerable. And so we know that that's the root of the problem. And so in many ways, researchers are now being tasked with kind of working with the symptoms or effects of it. But I think a lot of what we should be doing is really working at the root of the problem, making it so those structural constraints don't exist. And that's not really a question for scientists. That's a question about policy, and that's a question, that's a political question in many ways. A lot of disparities research originated because it was focusing on showing that, these huge inequities exist in society, and we can see it on not just a behavioral level, but we see it in people's health. And so I think where we focus the solution is where the problem is.
So on the question of adapting interventions, then do you feel that there's stuff that you can pull from your research that would inform how interventions should be adapted?
Yeah, and actually Judy Cohen, who really pioneered trauma-focused CBT, has been super responsive to a lot of the feedback from our trial, and she's learned things like the fact that a lot of sessions were structured in 90 minutes, but most therapists who are in the community see their clients for 60 minutes. That's just like a really obvious way in which a treatment can be changed slightly as a protocol. But something like splitting up one type, another panel was talking about the trauma narrative and how it's really important in trauma-focused CBT. Maybe if clients are not able to show up to every session, you have a way in which you can sort of do it remotely. Even those kind of simple solutions that are responding to the needs of clients.
Luther?
Yeah, so thinking about next steps of the work, just getting back to your earlier question, I think the mental health system has kind of evolved to be convenient for payers and providers. And so if you think about, going to the emergency department, it's just a place where we can go anytime we need it. And, when you go to a mental health appointment, it's between 9 and 5, Monday through Friday. And you know what? That's not when crises happen. And so, I actually did a survey of child psychiatrists in the United States, and we asked them, how often do you send your patients to the emergency department? And more than 60% said, yeah, we do. In times of crisis, we send them to the ER. And so, which is not surprising. So, there's actually been studies that have been linking outpatient care to increase emergency department visits. And if you call your provider, what does it say when you can't get through on the line? It says, if there's an emergency, go to the emergency department, right? Because of liability issues. And so it's not a total surprise that we're seeing this thing. And one thing I think we need to think about is revising our crisis care system and thinking of how can we get to families and design this that's best for them, that's most convenient for them, rather than trying to fit them in our schedules. We get surprised when we see increasing antipsychotic rates among populations, but we keep sending people to doctors, and so that's what doctors do, is they prescribe. So, what we see a lot in the environment is the way the system has been designed in and of itself. And so, and we also think about what do we get from outpatient mental health treatment appointments. From a psychiatrist, you get a couple minutes, you get a short assessment, and then you get a change in your medication. And so when I think about what a crisis is and when people go to the emergency department, it's way more complicated, and it has way more issues involved than you can deal with in a 15-minute medication appointment. And crises can happen actually not only as a function of mental health symptoms, but what's going on in the environment. And so they're complicated, and I think that we need to take a more macro look at these issues and ways to provide interventions that can reduce visits that may not always be mental health related. And I think there are models of care that are cropping up in different parts of the United States, but I don't know if there are national efforts to assess these and also spread our findings. So that's one of my thoughts. Take it or leave it.
Okay, Annie. So we'll go.
So where I'm from, Albany itself is city, but we're surrounded by rural areas. So in addition to racial disparity, we have to deal with rural urban disparities, and that can be an issue because these communities don't have any specialty clinics. And also we assume, I've done some community awareness events and stuff in those communities, and I realized that you assume that people know where to go, where the resources are, but they actually don't know. So providing basic information such as what are the symptoms are, where they can go if they know someone, they experience some issues, seem to really excite people about seeking treatment and try to kind of give them hope that they can get better possibly. So that's one thing important, but also there are a lot of scalable, we call scalable treatment, which is for eating disorder, CBT now are scalable treatment available. You can try to bring that to such disparity community, try to bring evidence-based treatment that way as well.
Okay, anyone from the audience?
Hello, thank you all for your excellent presentation. I was curious about stakeholder engagement in your research. So we had a talk right here in this room before this that was talking a lot about engaging stakeholders, and you have quite different populations that you work with. So I was wondering if you engage those communities and how and what you learned from that.
So my study did not have stakeholder engagement. So we did not work with parents of children with mental health or young adults with psychiatric illness. This was a secondary data analysis of publicly available data. However, I'm really grateful for PCORI because it's really brought stakeholder engagement to the front lines. And so all of their work that you have to clearly identify a stakeholder engagement plan. And I think this ties in very well to what we're doing is we need to have stakeholders identify the issues and work with us rather than vice versa. We need to have sometimes a bottom-up approach to solving these issues when we've historically always taken a top-down approach. So I think it's really important that we work with families and individuals and peers as we go through this process and bridging that gap between research and lived experience.
I can talk briefly about that. In our study, the site actually did recognize that suicide was an issue within their setting, and we had been doing a bit of work just broad looking at some of the mental health related presentations there. And so they asked us, can you take a deeper look into our data? We have critical incident reports and see what you find. And we found that, all right, the rates that are presenting are about 7 times that we see in the general population. So getting to sit down with them and their case managers and take a look at what's going on and what are you spending your time doing and what do you need assistance with, and then getting feedback through that process.
Suzanne?
I have a comment and a question. Probably I'm just paraphrasing what everybody has said, but I think we should remember back to the session before on dissemination and implementation, because I think what we're saying is that if you have an intervention you actually want to implement, make sure you can do so for the broadest number of populations, and make sure you're not, the way you're implementing something, make sure you're not exacerbating, increasing the disparity, because if you make it better for some people and not other people, the disparity is worse. So that's just my comment. I have a question for Lori. You had, and I think it was part of the assessment or something, but you mentioned idioms of distress. And we don't hear that a lot. And I hear it in my work. I was just wondering if you could say more about that, and what were some of the idioms that were studied?
Yeah, so when looking at the culturally competent measure that we used, it assesses risk for suicide over 4 domains, and one of those is idioms of distress. It didn't come up as a significant scale within our study, but as the sort of that population increases in diversity, recognizing that how risk is communicated and how they're going to share that with peers or case managers is part of a piece that needs to be involved in the training for that population, so they know that it might not just go according to traditional communication.
Okay, and I don't know the CARS at all. How do they measure idiom of distress? Or if you can say anything.
It's, I mean, like approximately a quarter, about 10 various questions assess those, assess that domain. So it really looks at just how maybe they've communicated risk in the past, how others have communicated risk with them, what sorts of things would be acceptable based on their cultural background.
Okay, great, thanks.
Problem.
Just a couple of comments. Good panel, and thank you for your hard work. On the larger issue of how are we going to address disparities, and kind of building on some of this talks, one question I'm thinking as I'm listening to kind of all the panels is how do you put all of these things together, right? I mean, a number of you are, let's say, working on youth suicide or youth in the emergency rooms, and because of the way things are funded, we do this project and do this project. But I think to actually address something like disparity, some of these things need to be brought together. And maybe one possible direction for a future NIMH meeting like this is it's almost like having pods or clusters of people working on related problems to really do some thinking about what could be done at the margin to pull together demonstration programs, building on kids in trauma and ERs, or whatever. So that's just, and I certainly agree with your point about the importance of having stakeholder involvement, not only at the community level, but at the policy level. Because if they're there, maybe they will work with NIMH and the researchers to say, well, my state is doing X, Y, Z, we could consider doing randomization or whatever to improve that. Just as an example, one of the things California has been implementing is a statewide mental health crisis intervention program, and one of their key goals is trying to reduce ER visits because of the exact problem you're saying. It's just increasing and increasing and increasing, and especially with young people. So we may have an opportunity to figure out, but then on the other hand, do we have the crisis intervention models, and will they work? Another brief comment I wanted to make around the project, the community trauma project. I think it's not commonly understood that when things are implemented in a public health model outside of a research study, effect sizes are going to be smaller. And some of that is for the reasons that were mentioned, like, well, they have to be implemented differently or they have to be done. But this is kind of the real world. If we were talking about hypertension, probably it would be the same thing. It's hard to achieve what can be done in a randomized trial. So I think the fact that there are small effects, but there are effects, is promising. You can always say, well, how can we get closer to what the randomized trials are coming up with, and what was the secret sauce? Is it 90 minutes instead of 60 minutes? But I think the nature of a public health mindset is, gosh, if you can get even small effects for lots of people, potentially that actually can be a good thing. So I just want to, encourage not feeling like we should just be, I mean, it's great to get to the effect size of a randomized trial, but it's not very common in public health implementation. Even so, I think we should address disparities and figure out how to do it, and how to do it from all the great work NIMH has been funding. So is it kind of like a pod approach? Might be worth thinking about.
Okay, thanks, Ken.
I have a question. It's a bit more technical. Again, thinking about the wide dissemination and adoption, this is about the CARS app. So I noticed that it was an iOS app, and so Apple products are very expensive, and what is much more common are Android products. And so I was wondering, is there an Android version of the CARS app?
So it was coded in iOS because the site that we actually piloted and does their intakes on iPads, and that's what worked for them. Mm-hmm. I coded it, and I only know how to code for iOS, so no, there is not an Android app.
Okay.
However, we worked to, it was funded through a grant, and so then there were additional iPads that were given to that provider so they could sort of expand that project.
Mm-hmm. I think actually making an Android version is actually a really important, probably next step, because most people have Androids. They're going to be using Androids, and you wouldn't want to disseminate it and then people won't adopt it because they can't use it on their devices. So just an idea.
Okay, thanks. I think with that, we're going to wrap up this great session. Thank you, everyone, for sticking through to the end.